All right, my pharmacology friends, let's get into pharmacotherapeutics for treating unipolar depression. We'll go through the major drug classes, beginning with tricyclics, monoamine oxidase inhibitors, so MAO-I'S. Then we'll get into the reuptake inhibitors. We have SSRI, selective serotonin reuptake inhibitors, and SNRI, selective norepinephrine reuptake inhibitors. Then we'll finish with atypical depressants antidepressants, and then our alternative therapies, so non-monoamine based approaches. Okay, so a lot of these different therapeutics are going to function, as you just saw, on reuptake inhibitors. So I'm just going to give you a little bit of some neurophysiology. So remember, let's start at the beginning. We've got dendrites up here. This is going to look really good. Okay. Sorry. Somebody has to think I'm funny, and it might as well be me. So there are normal cell parts up here. There's a nucleus, there's an endoplasmic reticulum, there's a Golgi, and these cell parts are manufacturing proteins like vesicles, which are filled with neurotransmitter. And then those neurotransmitters are trafficked along these cytoskeletal proteins. So not only does the cytoskeleton give a neuron some structure, or any cell some structure, but it also helps in trafficking, because vesicles don't just float through a neuron, they're actually trafficked by this cool little protein called kinesin. It's got two little feet on it like this, and it holds a big vesicle on it. And these little kinesin proteins, they walk down these filaments, and they deliver the vesicles down here to the synaptic areas. So this area here, this is the synaptic cleft or the synaptic space. So when there is an action potential, the cells depolarize, sodium, well, that looks like a W, that's an N. Sodium comes in, the cells depolarize, it becomes positive. That's going to trigger the movement of vesicles towards the synaptic cleft. What you don't see on here, but you saw in the last lecture with benzos, if you watched it, which I hope you did, do things in order, it's really important for your life. Okay, here's calcium. When there's an action potential, essentially what's happening, see where it says, well, I'll make it so you can read it, sodium comes in. So that means that sodium channels all along the length of this axon have to open. And these are voltage-gated channels, which means they open when that cell gets to a certain charge. So see how this charge is really high right here? That's the voltage that's going to trigger the opening of these. Another voltage-gated channel right here towards the synaptic cleft is the calcium voltage-gated channel. So once this action potential travels all the way down this membrane and it's excited, that's going to trigger the opening of this calcium channel, and calcium comes into the cell, and what that does is trigger the docking and fusion of this vesicle with the membrane. So now this vesicle is going to come here, it's going to dock, and then it fuses with the membrane. And vesicles are made out of the same phospholipid cholesterol compound that the cell membrane is made out of. So once it docks there, then it starts to unzip itself and then just empties out its products through exocytosis. And then the membrane is just incorporated into the cell membrane. So that's vesicular docking and fusion. So it docks, it fuses, and then we have neurotransmitter release into the synaptic cleft. And the more neurotransmitter there is in the cleft, the higher the chances that that neurotransmitter will bind to receptors. And remember, those receptor binding interactions are just millisecond in their time stamp. So they bind, they pop off, they bind, they pop off. And the more times they bind, the more the charge goes up, and the more likely it is that the cell's going to have its own action potential. Okay, so these are typical postsynaptic receptors. So there's a couple of other things we'll talk about in this lecture. We've already gone over an alpha and beta receptors lectures talking about the autoreceptors. So autoreceptors are presynaptic receptors that are triggered when there's so much of a substance. So in this case, it's serotonin. There's so much serotonin flooded this cleft. It's completely saturated. When there's so much serotonin, in the cleft, eventually it's going to be attracted to this presynaptic serotonin receptor. And when it binds, that sends a stop signal to the inside of the cell saying, please stop trafficking more vesicles down here. We have more than enough serotonin out here in the cleft. So we'll talk about some enzymes that are out here in a little bit that help degrade the serotonin that's there. The other thing that can happen to the serotonin or any neurotransmitter is that it can be sucked back up into the presynaptic cell through a transporter. And that is called a reuptake transporter. So rather than the body manufacturing more serotonin out of the tryptophan pathway, it can just take readily made serotonin in the cleft that's not bound to anything, suck it back up, repackage it, and then re-release it again. It's just a recycling mechanism. But the autoreceptor will limit the making and release of serotonin, and the transporter will continue sucking up serotonin until there's really nothing left here in the cleft that the enzyme hasn't already degraded. So those are some things that we can think of. We can either target these postsynaptic cells, we can target the autoreceptor, or we can target the reuptake receptor. So let's go through the drug types and see which one they're affecting, because the mechanism of action is all based on the physiology. I really, really, really want you to have a good understanding of the mechanism of action. If you understand that, you're going to know everything there is about how these drugs work. So we're going to first talk about reuptake transporters and the various types of monoamine-based therapies that are going to target them. So let's start out with one of the first drug classes that were used to treat depression, called the tricyclic antidepressants. Remember how we can make associations between the way drugs are named. So you'll see like amitriptyline, okay, all right, norepinephrine, imipramine, desipramine. See the amines in there, or iptylines, doxepine, tropyramine. Do you see how these look similar? Clopramine. So they all, depending on what company is going to sell them, there's going to be a variety of different names that it's sold under. Like amitriptyline is sold as Elavil. So knowing the name Elavil is, I guess, good for you if you want to, but knowing the generics, you start to build up these associations. Like when you see imipramine, like, oh, that sounds like triptyline, ipramine. That's probably a tricyclic antidepressant. So these are going to affect reuptake receptors, specifically serotonin, and this is the old school name for noradrenaline. So you'll see that used simultaneously. So we still use the term adrenaline all the time, like adrenaline and noradrenaline refer to epinephrine and norepinephrine. Nor just means no R or no functional group. The way that these drugs work. So here, let's find our tricyclic antidepressant on this picture and orient ourselves to all the other things that are on here, because we've got three different axonal projections or terminals. In red, we have acetylcholine, which we know is released sympathetic, parasympathetic, all over the body. In blue is serotonin. In green is norepi or noradrenaline. In oranges are histamine, which we know is prevalent in the brain and makes you really sleepy when it's around. And then in yellow, we have our tricyclic antidepressants. So when these drugs, these ipramine drugs, are used, what they do, that's a good picture for them. Let's use white. So here's some yellow, and what this drug is doing on this neuron is blocking the reuptake transporter. So when a cell is releasing serotonin, so see in blue, serotonin, out into the cleft, we want it to stay there, because we know that depression is linked with low levels of serotonin. If you can increase the amount of serotonin in the synaptic cleft, then you increase the amount of binding interactions the serotonin has with its receptor. If, however, the reuptake transporter is working, it's essentially a vacuum, and it'll suck up the serotonin and repackage it into vesicles. So these tricyclic antidepressants, they block the serotonin reuptake transporter, so serotonin floods the cleft. It also blocks the norepi or noradrenaline reuptake inhibitor or reuptake transporter. So instead of noradrenaline or norepi binding to its adrenergic receptors, and if it's adrenaline-like, remember those are alpha or beta receptors, and it would be trafficked right back up into the cell, repackaged or broken down by this enzyme we'll talk about in a second called monoamine oxidase. So what we have here is a blocking of reuptake for both norepi and serotonin. That means the levels of those are going to be higher in the cleft, increasing the amount of binding interactions. So we're going to increase norepi and we're going to increase serotonin. Okay? These level changes happen immediately. We can detect that via microdialysis studies, plasma studies, but again, you need some compensatory effects to happen with the brain because now we're going to be flooding the body with lots of neurotransmitters, so the body will need to adjust the amount of receptors it has postsynaptically to respond better to the amount that's now present in the body so that we can maintain homeostasis. This is a new homeostasis the body now has to get used to. Pharmacokinetics, they are oral medication. They're absorbed really well from the GI tract. They're strongly bound to plasma proteins, which means they can last longer in the periphery. They're very highly lipophilic. So that means they can last longer and have a longer distribution half-life. Their metabolism is mainly through demethylation in our first order, and then second order will be conjugation with glucuronides, so glucuronic acid. Remember, glucuronic acid is our stable enzyme for our phase 2 reactions that is prevalent throughout the lifespan. So even though the label or the levels are relatively stable, kids in general, they have really fast metabolism. So they're like little hummingbirds. Their respiratory rate is fast, their heart rate is fast, and their metabolism rate is fast. So they metabolize these drugs very quickly. Whereas you get older, those processes start to slow down. So there's still lots of ways for them to do glucuronic interactions or metabolic effects, but they do slow down with time. So we know that this drug is safe for most ages because of the glucuronidation. All right, side effects. All right, it sounds cute because it's a QT interval. QT, how fun, how cute. Not cute. Because this is altering norepinephrine, which we know binds to alpha and beta receptors, which are on the bronchi, the myocardium, the uterus, blood vessels, all over the place. If you now flood the body with high levels of norepinephrine, you're going to increase sympathetic outflow. So the most severe side effects are cardiovascular in nature. So you definitely want to take a look at not only the patient's cardiovascular risk and any history, but also the family history of cardiovascular risk. So you'll see orthostatic or postural hypotension as a severe side effect, where there's that faintness or dizziness or lightheadedness upon standing up. Tachycardia, well, there should be a Y in there, sorry for that. Tachycardia, so greater than 100 beats per minute in adults. And the most dangerous is really QT lengthening. So if you look at our waves on our EKG, here's our P, here's our QRS complex, and here's our T wave. P, remember, is atrial contraction. QRS, well, depolarization. We'll just say contraction right now. I'm going to talk fast. Okay, so atrial contraction, QRS is ventricular contraction, and the T is ventricular repolarization. So it's basically your rest. And what's happening when the ventricles are resting is that the ventricles are filling. Okay, so think about this physiologically. So atria contract, ventricles contract. Now, nothing happens. So this heart is going to overfill. Think about the myocardium now as a rubber band. If you stretch it a little bit, it'll have a little bit of a weak, ejection fraction or stroke volume. If the heart is really overfilled, think about the snap that's going to happen with that rubber band. If your patients have any myocardial dysfunction or dysrhythmias, that can be really dangerous to them. So we want to avoid things that alter the QT interval, and definitely pay attention to other medications that patient is taking. If they're taking cardiovascular medications, perhaps tricyclic antidepressants are not the best choice for them. Also, if you look at that slide prior, we saw that not only do we have effects of norepinephrine, remember to get norepinephrine, you also are going to have acetylcholine activity. So we can have some anticholinergic autonomic effects. So that's your dry mouth, the urinary retention, constipation. People really, really dislike their anticholinergic effects. And these are so sedating that they can actually be used as hypnotics to help with sleep sometimes. So it's recommended that they're taken at night because they do cause so much sedation and sleepiness. And there is quite a high documented amount of weight gain with these medications. There's definitely guesses that you could make just through logic, like why there would be weight gain. If there was lack of appetite and now we're adding a medication that perhaps restores food seeking or orexin activity, it wouldn't be surprising to see weight gain, but it hasn't fully been elucidated why there is such a substantial amount of weight gain on tricyclics. Okay, so those were the first ones that were created, your tricyclics. So those are mainly serotonin, norepinephrine, reuptake inhibitors. Another way that you can increase the amount of neurotransmitter in the cleft is to target the enzyme that breaks them down. All right, so we have tranylcypromine, which is parnate, phenylzine, nardil, isocarboxide, marplan, paraglide, unanil. Then we have our two that are selective. What happened? Come back. And remember, selective means two things. When a drug is highly selective, that means that there's less side effects, but that also means that it's going to cost more money. But let's talk about why that's important. So first off, we're going to pay attention to the fact that there is a MAO-B and an MAO-A. What does that mean? Okay, the other thing about these is that some of these drugs are reversible and some are not. And what does that mean? So let's take a look at that. All right, so as I mentioned, when there is an action potential, the vesicles get trafficked down, the neurotransmitters package, calcium drives docking and fusion, and then exocytosis is the mechanism for release of the neurotransmitter into the synaptic cleft. So in this picture, we're looking at dopamine, my favorite neurotransmitter, probably. Maybe melatonin. I love sleep. There's an Ernest Hemingway quote that says, "I love sleep. My life has a tendency to fall apart when I'm awake." And I feel like that speaks to me pretty well. But I digress. So here in this picture, we have dopamine, and dopamine's being released in the typical process, binding to its postsynaptic receptors, popping on, popping off, flooding the cleft, and some of it's going to get sucked back up into the neuron. So here's where the drug comes in. Here is this enzyme. It looks like a crazy seashell thing in this picture, but the way monoamine oxidase works is any dopamine that's left over that cannot be packaged into vesicles, because your body loves to recycle. It recycles iron, it recycles neurotransmitter. It likes to get around doing more work. We can all level with that. That's legit. I get it. So it will package anything it can into vesicles. But if there's not adequate vesicles there to package the excess neurotransmitter, then that neurotransmitter is broken down. And it's broken down by this big old enzyme. And here it's pink, MAO. In this case, it's B. Hang on one second, we'll get there. But anything that's not going to be packaged is broken down by this enzyme. So there's two different ones. And there is MAO-A, which breaks down into component parts just for either excretion or reusing. It breaks down norepinephrine and serotonin. MAO-B breaks down dopamine. So what that means is if you have a general monoamine oxidase inhibitor, it's going to block the enzymes that break down all of these. If you have a specific MAO-A or B, you're targeting just either NE and serotonin or dopamine. So you are blocking, here's Selgline. This medication is an MAO-B inhibitor. So it binds to this enzyme and prevents it from breaking down intracellular dopamine. That means it'll just hang out here, wait for a vesicle to be packaged in, and then be released into the cleft. So this is a way of increasing stored dopamine, which will then be released and bind and hopefully cause depolarization down here. We know dopamine's important for reward and for mood and for hedonic effects and drive and motivation. So the activation of this drug will be to increase levels of dopamine. MAO-A inhibitors will increase levels of norepinephrine and serotonin. Most of them, though, are just general monoamine inhibitors. So they're going to block all of those. Okay, so here's the other thing that I want you to know. I'm going to get rid of my drawing. God bless America. Okay, when a drug is irreversible, what that means is it comes here and it doesn't just sit there and block it. It just binds to it and degrades it. Are you kidding me? Sorry. I have a temper, but not right now. I'm Dr. B and I'm happy. Okay, so we have irreversible ones that bind here and they degrade it. The important thing to remember is if something is irreversible, this is now dead. It's a killed enzyme, speaking very simply. It takes 2 to 3 weeks to make new proteins, and enzymes are proteins. If somebody is on an irreversible MAO-I, that means if you switch them to another medication, they're not going to have new enzyme for at least 2 to 3 weeks. That can be really dangerous in some cases, as we'll see in just a second. So just keep that in mind. We have two. We have MAO-A, we have MAO-B, and then we just have the non-specific ones. You should definitely keep in mind which ones are just general. So these are A and B. Deprenyl or seleglene, which we just saw in that picture, is MAO-B only, and meclobamine or Ororix is MAO-A only, and the little asterisk means that they're reversible. When I say it's reversible, it means that that drug goes there and it sits there, and then it works for as long as it's in the body for, whatever its elimination half-life is. So it still is an intact enzyme, it's not killed. All right, pharmacokinetics of MAO-I'S. They are also oral, so they're absorbed through the GI tract very rapidly and completely. Their metabolism is hydroxylation or acetylation, so we don't see glucuronidation in there. That lets us know that it's probably not safe for all age groups. Elimination, max effect 5 to 10 days. It takes weeks to clear from the body. And also remember, it takes 2 to 3 weeks for new enzymes and proteins, because enzymes are proteins, to be manufactured. So if you put that person on a medication that grossly changes the amount of serotonin in their body or the amount of norepinephrine in their body, you can cause really deadly, toxic, dangerous things to happen. So please keep that in mind. That's dangerous. So the side effects, because we're really affecting wide levels of things like dopamine, serotonin, norepi, sedation or excitation, postural hypotension, and then you're really affecting blood pressure. So you're going to have a lot of different effects with autonomic things too. So peripherally, men experience inhibition of ejaculation. So that still means that they have the ability to achieve and then possibly maintain an erection. However, the time to ejaculation is lengthened, which can cause some sexual dysfunction, and definitely in relationships. Urinary retention, dry mouth, blurred vision. What does that sound like? Dr. B, that sounds like anticholinergic. Oh, guys, you're totally right. You're so smart. I'm so proud of you. And then if you have too much stimulation with things like norepinephrine being increased too much, tremors, insomnia, agitation, hypomania means it's not quite mania, but it's pretty close. And then when you have high levels of norepinephrine in the periphery, that means there's vasoconstriction in the periphery, so there'll be vasodilation in the central nervous system, which means you're going to feel kind of dizzy and have headaches and feel weird, have vertigo. Another thing you need to remember about serotonin is that it's made out of dietary residues. It's made out of tyramine. So tyramine is in all sorts of things. It's in foods, like all my favorite things, like cheese and red wine and avocados and like smoked salmon. I don't love beef chicken liver, but I do like bananas and cheese and yeast and chocolate. And yeast is what makes bread and makes pizza dough. So yeah, definitely. Oh, and I forgot beer and wine. So you need MAO to break down those foods because they're tyramine. And tyramine will eventually turn into catecholamines. So that's really important. If people are on these medications, they are supposed to avoid these foods because if they lack the MAO that's necessary to break the tyramine down, if I said serotonin earlier, I think I did. I was talking about dopamine. I'm sorry. Tyrosine is whatever. Let me just get through this, guys. But oh, you're kidding me. Okay. All right. If foods are eaten, the tyramine builds up and there can be a hypertensive crisis, tons of catecholamine release. So that's your dopamine, epinephrine, norepinephrine. That signals to the adrenal medulla to make even more norepinephrine, which can be really dangerous. Also, because the over-the-counter cold medications contain things like phenylephrine and pseudoephedrine, those should be avoided also because that cannot be degraded. Those are products that are similar, and they also use the MAO enzyme for degradation. So ideally, the patients would carry around a food restriction card with them or have that information stored in their smartwatch or smart medical device, or at least, or maybe a bracelet or something that lets them know they can't eat that. And then also something that's important, you can't give really high doses of epinephrine with these drugs. Like you have to reduce their epinephrine dose by 50%. So if you don't know somebody's on an MAO and you give them epi, they could be killed from that. So it's really important that people know that. One other thing that nobody really talks about besides me, as far as I know, is that St. John's wort, which is an over-the-counter medication that is sold for depression, it's an irreversible MAO-I. And it's non-specific, so it hits A and B. It's fine. I mean, people can take it. People report that they have really good side effects from it. You don't need a prescription for it. It works just fine. However, it's really important that they report it because if that's not working and they just go onto another medication and really increase their dose of or levels of serotonin or norepinephrine, then they can go into crisis and that could be deadly as well. Okay, then we have the most popular drug class, and these are usually the first type of drug people use, especially in treatment-naive individuals. They started in the 1970s, and then in 1987, the first drug to hit the market, SSRI-wise, was Prozac, which is fluoxetine. That's really the bread and butter of the SSRI and depression treatment. That's a really famous medication for us now in behavioral pharm. Fluoxetine is really efficacious in like the behavioral pharm studies with the forced swim tests, with the learned helplessness tests, the escape tests. And Prozac, yeah, that was the first one around, and that's fluoxetine. Then there's sertraline, sold as Zoloft. Paroxetine, sold as Paxil, fluvoxamine is Luvox, and citalopram is sold as Celexa, Lexapro. And these are just a couple of trade names. Remember, drugs can be sold under as many trade names as the manufacturer will allow the patent to be shared by. Okay, they have the most straightforward mechanism of action, so that's easy for you. They are considered more safe because they are targeted for just one thing. They work by binding to and temporarily blocking the serotonin reuptake transporter. Just like we talked about before, we have serotonin sucked back up into the cell and repackaged into vesicles so it can be re-released. When the reuptake transporter is blocked, then it doesn't get sucked back up there and it remains in the cleft, levels rise, and then there are changes to mood, which appear in about 2 to 3 weeks. One other thing I want to point out to you, I talked to you about MAO, monoamine oxidase, which breaks down intracellular levels. There's a small amount of MAO out in the periphery, but the main thing we think about in the periphery is COMT, which is another enzyme that breaks down serotonin. So I just want you to remember that for a second, because we'll get there. Okay, so selective serotonin reuptake inhibitors. So citalopram is It's not our fluoxetine, but it's a common one, citalopram, just blocks the reuptake inhibitor. Good oral absorption, also highly lipophilic, binds to plasma proteins, demethylated active metabolites. Remember, when there's active metabolites, there's going to be extended elimination. So fluoxetine is eliminated in 2 to 3 days, but it takes 8 days for its metabolites to be fully eliminated. So anything with active metabolites, it lasts for a long time in the body. Don't forget that. Side effects, this is highly serotonergic. And remember, serotonin, if you never took physiology, you should take physiology. Physiology is the best, and it helps you understand everything. Serotonin is a major vasodilator. So if you are altering to gross levels the amount of serotonin in the body, you're going to have major changes to vessel size, which is going to change the blood flow to an organ. Blood flow to an organ is usually concurrent with how much activity that organ is doing. So if you eat some food and now your stomach's churning, then blood flow increases to your organ. You have serotonin release, you get increased blood flow there. You get adenosine release, you get increased blood flow there. So that means you're going to have vasodilatory effects all over, and that's going to cause some weirdness. So nausea, vomiting is just because it's an oral medication, but it also is because serotonin affects appetite. Headache, because it's vasodilatory. Agitation, feeling restless. 1 out of 3 patients report sexual dysfunction because of this interruption with normal vasodilation. You need to have a correct and normal, the just typical vasodilatory response for both the clitoral and penile erectile responses. There's also a significant weight gain associated with SSRIs. When there's too much serotonin, we'll see a picture in a second, it leads to Serotonin Syndrome. These drugs do have a black box warning on them because when you give these to adolescents and then look at the data afterwards of teenagers who committed suicide, one commonality that they have retrospectively is that they were taking an antidepressant. So they do have have a black box warning on them, so keep that in mind. Patients should be monitored very closely with these, and they also really have to be counseled through that 2 to 3 week waiting period for any noticeable therapeutic effects to be seen. There is an overdose effect with these. If you have too much serotonin, you get massive amounts of CNS stimulation, which can also progress into tonic-clonic seizures, which are also known as grand mal seizures. So serotonin syndrome is just really, really increased serotonin. So as I mentioned, serotonin is increased whenever you need more activity somewhere, and it's vasodilatory. So you'll see things working overdrive, like everything. There is sympathetic outflow, so tachycardia, sweating, agitation, increased bowel sounds, which is essentially, we call that peristaltic rush. The body just is getting rid of everything in the colon. And then I mentioned tonic-clonic. Tonic is sustained contraction, and then clonic is referring to like convulsions, which are sustained contractions. So tonic-clonic is like a tetany followed by a convulsion. And then we can see hyperreflexia, which is part of, that's your tonicity. So we try to avoid high amounts of serotonin to avoid serotonin syndrome. This would be something patients are really at risk of if they were on a non-selective MAO-I and then switched to something like an SSRI. So imagine a patient doesn't report that they had been taking St. John's wort. It's irreversible. They don't have any MAO in their brain right now, and now they're on an SSRI that is really, really increasing the amount of serotonin they have. That patient would be at very high risk of developing serotonin syndrome. SSRI discontinuation, there is a discontinuation syndrome, about 10%, so 1 out of 10 patients report dizziness, nausea, fatigue, headache. They're irritable, they're anxious, they feel sad, they have nightmares, burning, tingling extremities, ringing in the ears, blurred vision. Lightning bolt syndrome is, I like to say it's just what it sounds like, but lightning bolt sounds like lightning comes from the sky and shocks you. Lightning bolt syndrome feels as if the shocks are going through individual nerves. So when we talk about drug withdrawal, it's the body trying to adjust to not having something on board to it. And the easiest way to fix withdrawal is to give the drug. So even though these drugs are designed to be discontinued probably after a year, and mostly, I mean, patients should be off of them after 2, people tend to stay on these because they feel better when they're on them, and they have a discontinuation or withdrawal effect from them. The higher the dose and the longer they're on the drugs, the harder it is to get off of them because the worse the symptoms are. The way that withdrawal works is so if something makes you really, really happy when you're on it, withdrawal means you're going to be really, really sad. And it's going to take weeks for you to get past that. So the longer you're on it and the longer or the higher the dose, the worse the symptoms are. And if you go back on it, then you're going to feel like this all the time. So why would you want to go through weeks and weeks and weeks of this when you can go back on the drug and do this? So when patients do want to get off of the medication, which they eventually should, your liver can only do so much. We don't want people to be on pharmacotherapy forever. We want to keep them on exactly what they need and nothing else. So there is a taper protocol for these drugs as well. And this involves multiple weeks, sometimes months, of slowly reducing the amount of medication safely to avoid things like this withdrawal effect, which will just drive the patient to continue the medication, which then puts them at risk for never going off of it. And it's important for the brain to learn what it needs to do. And that's really the goal of the drugs, is let's teach the brain what it's supposed to be doing. And now the brain knows, and we can take them off of the meds. So if you can find a way to get patients over this with a nice, very gentle taper protocol, that would be very, very desirable. Finally, there's the newer medications, which we see are starting to raise the stakes for revenue produced for medications. The SNRIs, these are usually not the first choice. We already said those are SSRI, selective serotonin reuptake inhibitors. These are selective norepinephrine reuptake inhibitors. You might see a couple of names that you know. Not only do they block the NET, or the norepinephrine reuptake inhibitor, they also block the serotonin one too. So let's take a look here. Here's our serotonin, and here's our norepi. All right, so here you see our MAO and our comp out here, breaking things down, doing enzyme things. The most common one, as we saw, well, the highest grossing is Cymbalta, which is duloxetine. Venlafaxine is Effexor. Desvenlafaxine, see the venlafaxine, this means it's got a little something added to it, a little something, that's sold as Prosteek. Menalcipran is Savella. Levomenalcipran, look at that, menalcipran, same thing, little something, Vetzema. So these are going to block serotonin and norepinephrine. So it's going to increase norepi levels in the cleft and serotonin levels in the cleft. Both of those will be higher, more binding interactions, and hopefully changes now to mood, appetite, sleep, and also alertness and cognition. All right, finally, we've got our atypicals. So these are not going to do anything that we just mentioned. They're going to do their own thing, but they have their own efficaciousness for depression, so they are used when other treatments fail. So as I mentioned, usually you start with an SSRI, maybe move to an SNRI. SNRIs have a very bad withdrawal syndrome. It's the same as SSRIs, but exaggerated, and it comes on a lot quicker. And then your tricyclics, and then your MAOs. Or what we see is, depending on the side effect that's bothering patients the most, we might pick an atypical based on their side effect profile. All right, so we're going to talk about really quickly bupropion, which is sold as Wellbutrin, which is also sold as Zyban. This is a fun little FDA bang for your buck. Zyban's an anti-smoking medication, or that's the way it's marketed, but it's just bupropion. So the company that sells it for depression as Wellbutrin, and then Zyban for anti-smoking, because it replaces dopamine, and maybe you don't want to smoke so much. Then there's trazodone, sold as Deseril, mirtazapine, Remeron, and we've already mentioned buspirone a couple of times, sold as Buspar. Okay, how does bupropion work? it is a reuptake inhibitor for dopamine and norepinephrine. Fun fact, that's the way that amphetamine works. And when bupropion is broken down into its metabolites, their metabolites look just like amphetamine. So it makes people feel really, really good. Because it's sold as trazodone, it's used in smoking cessation. There's really good side effect profiles with this. And the main reason people choose this when you look at side effect profiles is the sexual dysfunction. With all those other medications, we saw dysfunctions of that nature. Bupropion doesn't have any of those. So if that's the biggest complaint of patients, this is a really great choice for them because it doesn't have those effects. Trazodone is a drug that is so strong and so sedating, and it's actually now just used for insomnia. If it is used for depression, it has to be taken at night because it will knock you out. It is a crazy drug. I love talking about it. We don't have to know everything about it. It's a weird thing. It's called a mixed agonist-antagonist, meaning that it blocks the serotonergic autoreceptor. So if you remember, autoreceptors are presynaptic, and if it's an even number, then it's an inhibitory receptor. So trazodone, it blocks the serotonin 5-HT2A. Do you ever wonder, how did I learn all this stuff? How do I have this weird knowledge? Or is that just me? I don't know. I'm getting tired. You can tell my pictures look like a swamp monster. So this is the serotonin. Let's just forget about that. Let's just make it simple. The 5-HT2, it's an even number. It's an autoreceptor. So when there's so much serotonin out here, remember, it'll bind and then it'll turn off more production and more docking, fusion, trafficking. So if we block that, then we have no stop signal. And it works really nicely, but yeah, remember serotonin is sleep, so it really increases serotonin. So this is primarily used for insomnia now. It's super sedating. Mirtazapine, that's same thing, an autoreceptor antagonist, so it increases levels in the cleft. And buspirone is a serotonin agonist, so it binds to postsynaptic serotonin receptors, so you get increased serotonin from the postsynaptic cell. And it's a dopamine autoreceptor. So here's a D2, dopamine type 2 autoreceptor antagonist. So it increases serotonin and it decreases the sucking back up of dopamine. So you get an increase in serotonin. Let me just draw it over here. Increase in serotonin and an increase in dopamine. Cool. All right. Finally, I'm going to end with other treatments. I'm going to talk about these pretty quickly because I'm getting tired, y'all. Okay, so one thing that we know is really integral to treating depression is counseling. So let me just point out to you some data really quickly. What you're looking at here is percentage symptom reduction. So when they gave people who entered this trial a depression questionnaire, they're looking at the amount of reduction in their positive responses to depressive symptoms. So like, how often do you feel depressed? How many times do you go out every day? Have you thought about killing yourself? So they're looking at levels of that after their trial. Okay, so let me just orient you over here. So this is the group with the placebo. This group remained on the waiting list. So that kind of sucked. What are these colors for? These are for men and women. You can probably make a guess that women are in red and men are in blue because that's the color that men like and women like. All right, so let's go over here. So here's rates of reduction. So here's 50% reduction in symptoms. Let me draw a line here. So their study's over and we want to see them get 50% down. So those who went to counseling only had around a little bit over 50% reduction in their depressive symptoms, which is pretty good. We want to have some reduction, so that's a little bit over 50. But what's interesting now is if we look at those on just antidepressants, those are the same levels. So what we see is that the drugs have the same amount of reduction in depression as did counseling. However, what's most interesting is when people did those together, when they did both a drug and counseling, they worked in a synergistic way. So rates of reduction were almost up to 50 or 80% in women and 60% in men. So we would say that therapy and pharmacotherapeutics, counseling plus drugs, are synergistic in that they enhance the activity of the other. So not only is it important for people to be on medication when it's needed, it's way more important for them to be in counseling at the same time. If you just do counseling, you have the same efficaciousness. If you just put a patient on a drug, you have the same efficaciousness. When you put them together, now you're going to cause a synergistic effect. Okay, other treatments. Electroconvulsive therapy. It's usually a scary thing when you describe it to people, but what's really interesting about electroconvulsive therapy, so this individual is sedated, they're not awake for this. This is number of treatments needed to resolve suicide risk. So these are patients at very high risk with an active major depressive disorder diagnosis and a suicide plan. This isn't something people do forever. They just have a few treatments. So here, what we're looking at is the blue is cumulative reaching zero. So how long it took for everybody in the study to reach a zero risk. And what we see is after one treatment, people are feeling kind of better. So this is the amount of people that have zero risk that many weeks out. And then here's the amount of people that are reaching zero relative to treatment. Okay, so here's one electroconvulsive therapy session. So essentially this is an electric shock applied to the brain, and because the brain runs on electricity by ion conductance, it's kind of like restarting your car battery or doing a crash cart with a patient. Restarts things and they just keep humming along, and it's kind of like nothing ever went wrong. They're working pretty normally. So now you start to see rates of suicidality go down after 2 treatments, after 3, after 4, and eventually when you're out to 12 and 11, you're looking at 95% of patients having zero suicide risk. And you have essentially after 12, this many patients have reached zero. So what you see is that this isn't something that you have to do forever. It works really, really well, not just for depression, but for really severe depressive episodes and suicide risk where other pharmacotherapies don't seem to have any effect at all. Less invasively, instead of applying shock, you can also use magnetic force or magnetic field because these are particles that are positive and negative, so they're attracted electromagnetically. So transcranial magnetic stimulation is a unit that uses an electromagnet and a magnetic field, and it's applied on the surface of the brain. You don't expose the skull, it's just a giant magnet that is put in a very specific field pattern on the head to essentially, again, reset the trafficking of ions. What I want you to look at, we've known for a long time that ECT works, the convulsive therapy works. Now we're looking at the mean score on the depression questionnaire. So here we have at baseline how patients were feeling when they first came in and started the study. At 17 items, 30 is the highest score you can get for depressive symptoms, and the patients were averaging about a 25 on the depression questionnaire. And then they were divided up into either receiving electroconvulsive therapy or magnetic transcranial magnetic stimulation therapy. So here they are at baseline. And then after their couple weeks study, we see that there's a pretty big differentiation between the groups where the TMS group is feeling like I feel a little better, but not a ton better. Where the electroconvulsive therapy group, we do see this big reduction. But what's interesting is 6 months later, when they follow up with the patients, regardless of what group they were in, they both had the same statistical level of symptoms. So one is a little bit more invasive, one is minimally invasive, and 6 months out, they have the same efficaciousness. Where the big difference is the immediate difference. You have to take into account, A, if that person is not responding to drugs and you need to move to this route, or B, what their initial suicide risk is. If they have the most potent suicide risk and you're very concerned about them, the data shows that electroconvulsive therapy should be the immediate treatment at this point in time until we're proven differently. Okay, a very, very invasive treatment, we usually use this for seizure activity, is vagal nerve stimulation, where there's a very invasive surgery done to implant a stimulator and it's wound around the vagal nerve, and the vagus collects sensory information from all of the organs in the body and integrates it for the brain. Not only is there an electrode that's wrapped around the vagus nerve implanted, there's also a generator, pulse, like a pulse generator, I can't speak anymore, man, long day, is implanted underneath the skin of the chest. Some people respond to this and some don't. Non-responders, you still see the same alterations, like blue on a scan like this means low, like cold. You don't have enough of that neurotransmitter. So people that don't respond to it, they still have low levels of things like the neurotransmitters that you want. But ideally what this does is signal to these brain regions to make more like serotonin, dopamine, norepi. So those that respond have a really potent response to it, and they do have increase in neurotransmitter, but there's a chance that somebody undergoes this surgery that's super invasive and they don't respond to it. So this might not be the best way to treat depression. When you're looking at rates of these are patients responding to vagal nerve stimulation. Those who went into remission with long-lasting depression are here. And what you see is that we had more patients not going into remission and having improvement with VNS than we did for things like treatment as usual or control. Okay, the most invasive therapy that we'll talk about actually in class when we talk about epilepsy, woo, is deep brain stimulation. It's called deep brain stimulation because truly it is deep in the brain. There are 2 electrodes that are implanted into the deep thalamic areas of the brain. There is also a generator that is surgically implanted underneath the skin. And the idea is that there will be a pulse generated to thalamic areas. Same thing, it will increase the level, hopefully, of neurotransmitter production. This is really irreversible. And this is mainly used in Parkinson's because we want to trigger the substantia nigra to do some sort of dopaminergic activity. So if we know that dopamine is low in depression and low dopamine is concurrent with Parkinson's, and this works in Parkinson's, the idea was, well, maybe this will work for depression. Just know what that is. I don't want to say anything more about it right now. This is depressive severity and function over time, baseline, postoperative. Sham means that they implanted an electrode. This is why I don't want to talk anymore. I'm getting tired. They implanted an electrode, but it didn't have the pulse that they needed. Why you do a sham surgery instead of just a control group is what if that person's effects were just from the surgery or just from the anesthesia? So they have all the same protocols as somebody with an actual working deep brain stimulator, but it doesn't actually work. It's just implanted. Isn't that fun? Okay, and now you're looking at their Beck depression inventory scores and how they're doing. So here's at baseline. You see that they have very high scores on their different depressive rating tests. Post-operatively, we see that rates start to go down a little bit. Sham group that is not receiving any active stimulation, we see some levels going down. Active stimulation, we see levels going down quite a bit. 24, we see levels going down even more, 1 year even more, 2 years even more. So it does seem to be that the longer these electrodes are implanted, the more of an effect this has on depressive symptoms. We do know that depression is common in Parkinsonianism, so it might be a concurrent effect that when they get this surgery, it might help with their depression, but it is getting to the point where physicians are referring patients to try DBS surgery if nothing else is working for their depression. And then finally, there is light therapy. It's even sad to say. Seasonal affective disorder. I live in Buffalo. Maybe you guys do too. Seasonal affective disorder. It's literally abbreviated as SAD. Like, how depressing is that? Literally. So this is postulating that we need the sun to help us feel good. And when the sun's not out for a long time, you get cranky and you get depressed. It's called seasonal affective disorder. And it's definitely a real documented thing. And what people did here, there's these things that are called light boxes. They're much smaller than they are in this picture. She's got a 90s haircut. So old. This is a light box, and it is recommended that people hang out in front of their light for various times in the day, depending on the severity of their symptoms. And this is meant to mimic the wavelengths of the sun. So even if the sun's not out for 7 months a year in Buffalo, you could sit with your light and hopefully feel better. Here's where it gets really crazy. Here's a study where they gave half of the patients their Prozac, so they gave them fluoxetine, or they sent them home with a light box. Now when you look at their mean change, these lines are essentially on top of each other. So let that be the final point of my lecture. There are so many different ways that we can treat depression. We have our SSRIs as first choice, SNRIs, tricyclics, MAO-I'S, atypical drugs, invasive drugs and surgeries. And guess what works just as well as fluoxetine or your Prozac? It's sitting in front of a light box every day. Super non-invasive. But remember, we have drugs that are synergistic with counseling, with therapy. So same thing would go for the light treatment. That will fix something going on in the brain, but that's not going to fix the other stuff that will be remedied with in a synergistic way with counseling. All right, y'all, man, I gotta go to sleep. I hope you could answer this question about cheese and wine and what medication they're on. So think about that. Get back to me. Have a good night.